Hi, my name is John Pilcher. I'm a bariatric surgeon in San Antonio. And in this little video clip, I'm going to talk about the pain and nausea situation after bariatric surgery. A lot of patients ask us about, after my sleeve, after my gastric bypass, what's going to be the pain and the nausea situation? It's a smart question because some patients have been through surgery before. A lot have not been through surgery before. Maybe they've had negative experiences, maybe positive experiences. And the good news is that bariatric surgery, because it's planned, it's something that we get a chance to prepare our patients for. We get a chance to actually prevent the onset of much of the pain and much of the nausea and sort of have a preemptive pain and nausea strategy. Now, this is different than the old school pain approach. Back when I was in training in the 90s, we would respond to pain after it occurred, after the surgery, and we mostly used one category of medicines, which was the narcotic opioid class of medicines like morphine, IV, and Norco and Dilaudid. And these things were effective for pain, but they had a lot of side effects. And so the more modern approach is to look and say, let's stop the pain or blunt the pain response before it even begins. And on the nausea piece, that's positive as well, in the sense that a lot of the nausea came from anesthesia medicines, which have gotten a lot cleaner over time. And then a lot of the nausea came from the use of those self-same opioid narcotic medicines, which we're moving away from. And now, obviously, the newer strategy with less pain and less nausea is a good thing in its own right. But the other cool thing is that less pain leads to a quicker recovery, shorter hospital stay, quicker time back up to normal activities at home, and quicker time back to work. So this is a good thing all the way around. Now, before I talk about the new strategies, let me set the scene with a little bit of more discussion about the old strategies of opioid narcotic pain control. These opioid narcotic medicines, they're effective in treating surgical pain in the first 24 or 48 hours, but we buy into two different categories of downsides or side effects with meds like morphine, Norco, etc. So the first set of side effects are the ones that happen more or less immediately after the meds are administered. First of all, patients become drowsy and sleepy. That means that they move around less. The second thing is that drowsiness and sleepiness involves some respiratory suppression. So there's a bigger chance of lung infection or simpler issues such as atelectasis. And then the other side effect of the medicines that's expected is that it slows down the whole gastrointestinal tract, which creates nausea, and it creates a slowing of the intestinal tract recovery so that people have this condition called ileus with food backing up on them, slow return of bowel function. So all these things lead to a greater degree of side effects and longer hospital stays. Now, later on, there's another set of problems or complications or side effects. First of all, use of these medicines can, in a few patients, lead to long-term chronic pain. Beyond like 48 hours from the surgery, the pain medicines don't actually treat the pain, they just suppress the pain. And what I mean by that is that they make the pain deadened for that short time period where the medicine is in your system, but it's not making the pain go away, it's just putting it on hold. And I like to make a comparison with taking out a bank loan. You take out sort of a pain loan, and yes, you don't have to pay the pain right now, but you have to pay the pain later with interest. And so definitely there's a transition point, 48, 72 hours after surgery, where we want to really move away from the narcotic opioid pain medicines because they're not helping with the recovery at that time. And there have been a few patients, not a great number, but still a tragic number of patients who have gone into chronic pain syndromes and chronic long-term opioid dependence with all the life-destroying side effects that go with a narcotic dependence over time. Now, in the 90s and the 2000s, we did use some numbing medicine, but we didn't use it very thoroughly or intensively. It was mostly just on the skin level. And as far as the nausea, which did happen regularly, we gastrointestinal surgeons kind of assumed that because we were operating on the stomach and operating on the intestine, the sleeve and the gastric bypass, that we were creating the nausea and that the nausea was caused by what we were doing surgically. But we've learned as we've moved away from the opioid narcotic medicines that those side effects were the main things causing the nausea, and the less of those meds that we use, amazingly, people have very little nausea from our surgery. So people can move very quickly into swallowing fluids and maintaining their own hydration. Nausea was also caused to some degree by the anesthesia medicines, but the anesthesia medicines have gotten a lot cleaner over the last few years. So the more modern preemptive approach is to do everything that we can to stay ahead of the pain and the nausea, to treat it before it actually begins, and then we can use small doses of kind of synergistic medicines after surgery as needed to treat the pain and the nausea. So the prevention strategy begins before the patient even arrives at the hospital for the surgery. It starts with hydration, and we've learned that it's actually useful for people to drink fluids on the day of the surgery up until they arrive at the facility. Having better hydration does lead to less nausea, and IVs are easier and the body behaves better under anesthesia. Patients are also going to get a couple pain medicines before surgery even begins. They're going to get a medicine called gabapentin, which is kind of a pain nerve calming medicine, and they're going to get plain old Tylenol, which in synergy with our other medicines is actually very effective. Patients are going to get several anti-nausea medicines before surgery begins. They're going to get a cool new medicine called aprepitant, which works directly against the leftover anesthesia effects of nausea. They're going to get a scopolamine patch. Most people have heard of the patch. And they're going to get a dose of a certain type of steroid that's going to also suppress the nausea before the surgery begins. In the surgery, there are two big things happening. The anesthesia doctors are going to use the types of anesthesia medicine that are the least nausea-inducing. Propofol is a big one in that regard. And then we surgeons are going to use a lot of numbing medicine, not just in the skin these days, but extensively in the muscle tissues where the nerves actually travel. And the cool thing is that we have numbing medicine now that lasts for 72 hours. So it's going to prevent the onset of the pain, or at least dramatically reduce it. And by the time it wears off 3 days later, much of the trauma and inflammation has already settled down, so the pain sort of never happens, which is actually the best outcome. After the surgery, we're going to have kind of a scheduled set of synergistic medicines that are given, continuation of the acetaminophen, continuation of the gabapentin, some anti-inflammatories like Celebrex or Mobic, and all these are going to keep the pain kind of at a minimal level. And then in small doses, we do use those good old-fashioned opioid medicines, a little bit of morphine, a little bit of Norco, but people are needing so much less now, and most often people go home and they don't ever take those medicines anymore, which in my previous experience in the 90s and the early 2000s, people would take Norco for 2 weeks after the surgery. That was kind of accepted, but now 0 at home, which is a much better recovery process. Beyond the medicines, the other big change after the surgery is that all of us, the whole staff, are focused on an active recovery. So we now, because patients are alert and they can move around and they're not over-sedated with our opioid medicines, they can, and we want them to be up and walking within an hour or two of the surgery. And being up and being active improves the lung function, it improves the urinary function, it improves the gastrointestinal function, and then from a pain perspective, it also reduces the pain, because a lot of the pain is like a stiffness and a spasm that happens, and the sooner people are up and moving, the less stiffness and the less pain that they have. And then of course this sort of philosophy of active recovery continues not just in the hospital, but in the whole recovery process over the first couple of weeks after surgery, people getting back to normal sooner and sooner after the operation. I personally let my patients drive 2 or 3 days after surgery. These small laparoscopic incisions are pretty strong over the first couple of days, so I'm not going to give my patients any special activity restrictions, and they'll have some soreness. There's a little bit there, but they can be going up and down stairs, they can be out and shopping, a little bit fatigued, but not really laying in bed. Definitely not laying in bed for the recovery. So putting all this together, these days we mostly see people sail through surgery with very little nausea and a level of pain that would be best described as soreness rather than major pain. People get back to their normal family activities and their normal work activities by 1 week, or certainly by 2 weeks after surgery, so that the operation has all of its positive impacts and very little of the lasting negative impacts that we used to just kind of expect.